So the purpose of this webinar has been to describe a little bit, mostly to people who are not clinicians, about the complexity behind asthma. Because as you know, it is sometimes quite challenging for doctors to understand the mathematics, but I realize that sometimes even simple things that we consider simple, as doctors, can be a bit perplexing. So we'll try to give you a little bit of this complexity, and of course we can discuss at the end. Well, the first slide suggests what you already know, that asthma is really very frequent. So all around the world, you find people with asthma of all the different ages, and it is a lot. You know, starting some places it can be 5% of the population. In some other places it can go up to 20 or 30% of the population. So it is really a very common condition. But however, what is asthma? And that's very interesting to know that nobody really knows exactly what is asthma. There are different aspects. So first of all, the word asthma appeared for the first time in Ilias. So that's a very ancient Greek text. It's about 3,000 years ago when it came up. So for anybody who can read Greek, you can see here that it says the word asthma for the first time, but it does not necessarily mean a disease. At that time, it was somebody who was running, he was chased, and he was panting. He had the difficulty of breathing. So this is the first time that it was mentioned. And already quite early, it starts being described again in a more medical sense. So the first one who used it in a medical sense was Hippocrates. He was the one who's used many of these terms in a medical sense anyway. And probably he thought he presented it as a symptom, not more as a disease. And he said that it correlated with the climate and with the location. But then you already start seeing about different phenotype, different presentations of asthma, even in these ancient texts. For example, Areteus presents something which is we would now call exercise-induced asthma. He suggests that if you get something from running or exercise, or you have difficulty in breathing, then you call this asthma. While Maimonides, who wrote a treatise on asthma, suggests that symptoms often start with a cold. And this is a typical presentation of what we call now the virus-induced asthma. And he also associated asthma with pollution. However, what we see today and what we call today asthma is something which is really very variable. And you see here, this is the prevalence, so how frequent it is in different parts of the world, and goes up to from 15% in people in places as different as El Salvador or Australia, going down to very little as 1 or 2% in places like China or Greece. But what is even more interesting is not the variability between the different countries, because you could say that each country, because of climate, because of different cultural conditions, you can have big differences. However, you can see big differences, huge variability also within one country. And a very good example is the UK. If you see here, can you see my pointer, actually? Can you see the pointer?
Yes, we can.
Yes, we can. Okay, good. So I was showing up here in the UK where in the Isaac study there were 6 or 7 or 8 centers that took part, and you see that the lowest center is about 15 or 17%, and the highest center is about 35%. So this is a really big difference, and this is something that we have observed, and we observed many times. You can also see down here in India with a range between 2% and 20%. So there is a very big variability even within different cities. And I think also, Marek, you have observed that in Poland as well. Yeah. There has been a study that different cities in Poland would have quite different prevalences of asthma. And what is interesting is the other thing is that when people move from one place to the other, they inherit the incidence from where they go. And that's in a time-dependent manner. So it seems that there is something particular in different places, but this is not a wide scale, but in the city, in the country, perhaps even in the neighborhood, where there is induces asthma. Now, when people try to define asthma, they have used many different ways. And unfortunately, we don't have an asthma definition which can be precise and can be agreed upon. So the current, so the most popular, let's say, or the one that people would refer to most is the one by GINA, the Global Initiative for Asthma, which is a large organization around the world with people who deal with asthma. It has changed its definition for asthma in 2014. The previous one was even more general. The current one suggests already that asthma is a heterogeneous disease. It is usually characterized by chronic inflammation. So I was saying that the current definitions of asthma are quite wide and suggest this variability. Not only they suggest, but there are within the different definitions quite a bit of contradictions, or at least they are not identical to one another, especially when it comes to young children. So there is a disagreement, which has not been settled yet, on whether we can call something asthma in kids less than 5 years or not, and whether we can have it at all. In the next slide, I'm showing an exercise that we did a few years ago when we were trying to find or characterize the best, the ideal, or the most fitting definition for asthma by using all the different definitions that have been available through different guidelines. So you see each one of the columns is a different guideline from different parts of the world. Australia, this is GINA, different types of GINA, the Japanese guideline, American ones, the UK ones, and on the lines are different aspects of the definition. These aspects have to do with, for example, inflammation, or the types of cells, or symptoms, etc., etc. And I'm not sure if you can see in detail, but you will see that there is absolutely no line that all the definitions are identical. And there are, of course, many aspects in common, but there is also quite a bit of difference on how people prefer to actually combine these elements in order to define asthma. So at that time, it was 2012. In the next slide, we have used all these definitions in order to come up with something which is composite, which is actually the result of all these definitions, suggesting that asthma is a chronic inflammatory disorder which is associated with variable airflow obstructions and bronchial hyperresponsiveness, and it presents with specific symptoms. Now, today, actually, there are people who accept most of that. For example, currently bronchial hyperresponsiveness is out of the definition, but the remaining aspects are in. And also there are groups that suggest that we should define asthma only through symptoms and not suggest any type of pathophysiology behind it. So still, the definition of asthma is argued. Let's go to the next slide. And if you can press it twice so we can have the full deployment of the slide, which suggests that asthma changes a lot through the ages. So you have a maturing immune system, and this is probably you need to show the whole slide because this is all overlapping, one picture over the other. And they start from early life and they evolve throughout life, actually, but certainly through childhood. And also there is an increase in the size of the lungs and also an increase in the mechanics of the lungs. So these combinations produce at each time point a different clinical characteristic. And as I mentioned before, this happens throughout life, but there are some people that suggest that the fifth birthday, that the age of 5, is an age over which we can call something asthma, mostly because we can characterize its lung function. And under the age of 5, we can't. But this is something that, as I mentioned, that it is argued. Now, in the next slide, we can see another way that has been used to classify asthma, and this is severity. This is a little bit old-fashioned, is not used so much anymore, and it's about 20 years old. So suggesting that depending on symptoms in the day or in the night, depending on lung function, you had 4 different levels of severity. Intermittent asthma, which was the milder one, then you had mild persistent, moderate persistent, and severe persistent levels of severity. This has changed because in order to define it, you needed to take into account also treatment, because you could have or not have any of these symptoms depending on whether you took your treatment and whether your treatment was effective. So because of this, then there was the next step, which is in the next slide, of classification, an important classification on asthma, which is the idea of control. The idea of control is how well you are while you're receiving your medication. So you can be very well controlled. Basically, if you don't have any symptoms, you don't have any limitation on activities, you have normal lung function, you don't have exacerbations, this means you are controlled. Doesn't mean that you don't have asthma. It means that with the level of medication that you take, all your symptoms are controlled. Then you have another group which is partly controlled, where you have some symptoms or some exacerbation. And finally, if you do have active symptoms and limitations, then your asthma is uncontrolled. And currently, this is what is used mostly in order to inform treatment. So basically, we base our treatment on whether the patient in front of us has a disease which is controlled or not controlled, and we increase or decrease the medication. So let's go in the next one, in the next slide, where, as we have mentioned, the classifications of pediatric asthma can be around age. So we have different age groups. For example, the infants, the preschoolers, the school-age kids, and the teenagers. We have the severity, and we have the different controls. And also, we have this idea of phenotypes. And phenotypes have been used. The word phenotype has been used for quite some time. Actually, it's a century where this is used, and we can go to the next slide. It has been used in many different ways. It started from genetics, actually. The original idea was to contrast the genotype, so the characteristics that define the organism, and what is the product, what you can see. So that was the phenotype. The way that we use it nowadays in relation to different types of disease is that the phenotype is what we can observe around a subtype of the disease, which is apparent at the time of consultation. So when you see a patient and you see specific characteristics within that disease, you can say that this patient has this type of phenotype or the other type of phenotype. However, the first time that the idea of phenotypes has become quite popular was, I think, about 20 years ago, or perhaps a little bit more. It was early 90s, in the next slide, where a big prospective epidemiological study has actually looked into, in 2003 was published, so it's about 20 years ago. So they looked retrospectively, actually, in a prospective cohort, in a birth cohort, and they have observed that there are some kids that have wheezing symptoms in the first few years of life, and then this goes away. There are some that start, and this persists, but if they don't have atopy, this will slowly go away as a population. And then you have some that do have this wheezing plus atopy, and these will eventually go into becoming the real asthma. And this has been used for many years as the idea of a phenotype, although the truth is this is not a phenotype, because you cannot really say whether a child, whether a person belongs to any of these groups unless you wait until its 11th year. Even more, in the next slide, people have repeated this type of design and tried to identify these natural history phenotypes or patterns, and they have realized that, of course, things are much more complicated than just 3 groups, and you can group people depending on whether they have continuous asthma or whether they have asthma or wheeze for different periods of time, and you can have different subgroups there. However, after that, after people realizing that natural history is very important, but it does not help in everyday practice, they started looking in different types of disease, different phenotypes, that can be useful in one way or the other to inform treatment. And we can see in the next slide different ways that people have tried to group asthma by phenotype. For example, we mentioned about severity and persistence, and there are different characterizations. For example, difficult asthma or brittle asthma or problematic asthma. By trigger, we mentioned already about exercise, virus, and different specific triggers of the disease. Then in relation to time, for example, seasonal asthma or nocturnal asthma. Sometimes looking into mechanism like aspirin-induced asthma or atopic asthma, or sometimes by demographic, occupational asthma, childhood asthma. These are different categorizations, and all of them have some kind of usefulness in order for managing or understanding the disease. Now, in the next slide, again, there is more or less a description on how the idea of phenotype has and is being used. And you see that they are quite different. So people have used it in relation to any observable trait, like a partial phenotype, for example, having bronchial hyperresponsiveness or not having bronchial hyperresponsiveness. And there are other groupings, like, for example, difficult or severe. And in some cases, there are also a hypothesis behind it about the mechanism, which, as I will tell you in a little while, is currently called endotype. So one of the most important and interesting phenotypes around asthma is the allergic aspect of it. We'll go in the next slide. So the mechanisms of asthma, the more they're of course complex, but to a big extent they are associated with immune defects, central immune defects. So very early, already from the 19th century, before we even understood about the relationship of asthma and allergy, there have been some observations. For example, asthma and hay fever had very common characteristics. They were responsive, for example, to removal of a potential cause like dust or pollen. And there was an observation that asthma could be transferred by blood transfusion, suggesting that there is, let's say, this systemic immune element. So currently, in the next slide, there are different ways that we understand allergy as well. But according to the definition of allergy as a long-term immune dysfunction and inflammation, asthma is within this big umbrella of these immunological diseases. Of course, this is only one perspective, where all the different immunological aspects of asthma are under the idea of allergy. However, there are different views about what allergy means in this case. And if we go in the next slide, there is a view that allergy is a specific pathway among the different pathways that may lead to asthma. So on your left, you have a specific immune pathway, the one that goes through the Th2, the T helper 2 cells. But then on your right, you have a different pathway through innate lymphoid cells that can lead to the same kind of cellular infiltration, eosinophil infiltration, and this has been called by some non-allergic. So this is one of these discrepancies that I was telling you about. Whatever they are, whether they are, you should call them or not call them allergic or non-allergic, the truth is there is quite a bit of variability in underlying mechanisms that will eventually present themselves as clinical asthma. Let's go to the next one. Because of this complexity, there have been many people working on trying to put things, let's say, in boxes, not exactly in order, but try to describe what are the associations of these different presentations, these different phenotypes. And you see here, so Sally Wenzel has been one of the people that have been working a lot on the different phenotypes. And you see here, one important element that she had identified and she described was when the asthma started. So early or childhood onset asthma is the most frequent and most typical disease, but also you can have disease that starts late, adult onset asthma. And there the balance is between different subtypes of asthma. For example, here you can see eosinophilic asthma where eosinophils are the main cells. responsive to steroids, another characterization, exercise-induced, allergic. So, and you can see how these are described, and this, of course, is conceptual. It's not a result of any type of analysis, but rather from experience and from different epidemiological studies. And the same group, if you go to the next slide, and continue describing the different subtypes of phenotypes of asthma. To a big extent, it depends on what exactly you want to do and what you want to achieve by dividing. Here you have, again, the division between adult onset and childhood onset asthma, suggesting that childhood onset asthma is much more Th2-like. So the immune response there is, in most cases, closer to that part. Well, the adult onset asthma has more of this non-Th2 type of phenotype, which is true. What is not exactly true in this graph, for example, is the relative size, because the relative size of non-Th2 adult onset asthma is much smaller. But here, for the for exemplifying it, they're showing it as two equal categories. Non-Th2 small. So generally, adult onset asthma is much less than childhood onset. So actually, it might be something like 80% of cases of asthma that would start in childhood, and the remaining would start later on and during adulthood at any time. So in the next slide, again, a different approach where the importance is about the relation between symptoms and eosinophil inflammation. Eosinophils are very important cells, and so you see here in this 2008 publication that there is some disease which is concordant, where you have more symptoms with more eosinophils, but then you have also some disease where you have lots of inflammation but with low eosinophils, and these are because of different types of cells, or you might have quite high levels of eosinophils, but you don't have so many or parallel symptoms. Again, this is a type of approach in order to characterize different phenotypes. The next slide is an approach that we have taken several years back when we were thinking about pediatric asthma in particular, and about phenotypes that are very common. And this was mostly for highlighting that there are some triggers which characterize also different mechanisms. And they are very frequent in childhood, the most frequent of which is virus-induced asthma. And here is clearly the trigger as the main characteristic of the phenotype. Then you have the exercise-induced and the allergen-induced, which is not necessarily the same as allergic or atopic asthma. So allergen-induced asthma was clearly defined as asthma that was triggered by the allergen. And of course, the mechanism would be allergic, but the allergic concept was actually quite wider than allergen-induced. So you could have allergic people that have virus-induced asthma. And then we went on and tried to describe phenotypes within the next document, which was an international consensus on pediatric asthma, which is the next slide. And we tried not to be very precise, so it was more artistic in the idea that you do have different volumes of patients, different numbers of patients, and you do have overlap, but you also have many different types of combinations here. This is also what we have found with Fractal, in the Predicta cohort, that you find the typical virus-induced, exercise-induced, allergen-induced, and multi-trigger asthma, but you have different types of combinations as well. Now, going to the next slide, I think an important notion is that behind several of these phenotypes, you do have quite specific and different mechanisms. And this is the idea of endotypes, as I will present to you in a moment. But you see here on the upper right, you have the descriptive mechanism of exercise-induced asthma, which is quite distinct of the allergen-induced asthma or the virus-induced asthma that are described as well. So it seems that some of the phenotypes can also have particular pathways and particular mechanisms behind them. But this is not, a one-to-one relationship, because there is all this overlap that I mentioned before. Another similar mechanism, a similar example in the next slide is obesity. And obesity is associated with asthma. Sometimes obesity is seen as a risk factor. So the more obese you are, the more you have a risk for asthma. But then on the other hand, there are some people which obesity is the main driver of their asthma. So in this case, it is a phenotype, because also we have found that if these people lose weight, then they also lose their asthma. And there is a quite well described mechanism, which is both mechanical, but also immunological, on how these people who are overweight actually have a specific type of asthma. So all this discussion, and let's go to the next slide, all this discussion about the clinical presentation and the mechanisms behind has been kind of organized, and people have tried to put it into a framework, suggesting that what we see is what we should call a phenotype, and then under the phenotype there can be different specific mechanisms, and they call these endotypes, and they tried to describe and associate the clinical presentation of the phenotype with the endotype. Unfortunately, this is a theoretical construct, and with the exceptions of very few specific examples, generally the idea of this of endotype and phenotype is something that, as I said, until now, it's just more of an idea. But we need to live with it. Similar to the constructs about phenotypes, in the next slide, people have tried to make asthma frameworks based on endotypes. And this is, again, an interesting approach, where you have elements like, for example, lung function. On one hand, that's one aspect of it. You have adaptive and innate immunity. On the other hand, you have different, things on the lower left, for example, even the perception of symptoms can change the clinical presentation, and different other aspects which interact in order to present, let's say, the clinical picture and the control of the disease and the presentation of the symptoms of the disease. In the next slide, we have a much more, let's say, pragmatic approach, which has been useful, and it's also been very useful recently, is the cellular infiltration in the inflammatory type of phenotype. So this requires, of course, somebody to do a bronchoscopy and identify the cells that are present in the bronchial mucosa. And based on that, people have seen that the majority, of course, is the eosinophils. So eosinophilic asthma is the one with eosinophils are predominant, and that's most of it. But there are cases where you find neutrophils, and you call this neutrophilic asthma. There you have cases where you have mixed both eosinophils and neutrophils and other types of cells. And you also have some cases where you don't find infiltrating leukocytes, which is strange because this is a prerequisite for inflammation, but it's called polygranulocytic. And there is still ongoing debate on how important and how much we should base our treatments based on this type of phenotypes. And in the next slide, I'll show you what's the weakness of this approach. And the weakness is that although if we do the bronchoscopy, we do find the cells, if we repeat the bronchoscopy after some time, it doesn't mean that we'll find the same types of cells. So the stability of phenotypes is not ideal. So when it has been done, actually about half of the cases continue to be the same, and the other half has changed. If you do that with statistics, it means that you don't have really a very high chance of having really one phenotype, but it probably is much more dynamic. So this is, as I said, this is something which is ongoing, and it's very important because specific types of cells will respond to specific medications. And this is particularly true with eosinophils, because eosinophils are the ones that respond to steroids, which is the main kind of treatment for asthma, but also eosinophils respond to the newer anti-IL-5 treatments, which are so what we don't have at the moment is actually medications that would really deal with neutrophilic inflammation. Some people suggest macrolides or something else which is outside the main asthma treatment aspect. But this idea that you do have cells and the cells respond to treatment is an important one, because it gives you, let's say, the cellular or inflammatory base of asthma. Let's go to the next one. And different aspects and the way of evaluating things is how well you can respond to treatment. So treatment response is again one phenotypic characteristic that's quite often used. So, treatment-resistant asthma is a particular phenotype, and particularly steroid-resistant asthma. However, as you can see here, the response to steroids vary quite a bit. And of course, the majority of cases would respond. If you see here the bars, this is from different studies. But there are some cases that will not respond, even will get worse with this. So the response to treatment is another phenotypic characteristic, which is, of course, presumably, it is associated with the type of inflammation that you have in the background. Let's go to the next slide. Now, of course, there are many different ways of finding phenotypes, of characterizing phenotypes, and people have started doing these data-driven approaches. So we have had all the different type of data-driven approaches, like here, for example, a latent class analysis, in order to get down to different clinical phenotypes. Starting from bigger or smaller groups of people, and as I say, using these methods. And in some cases, these appeared to be useful or started making some sense. However, and I will show you, for example, that here you have, for example, these were kids with had either cough or asthma, and you have here persistent cough, transient cough, atopic persistent wheeze, non-atopic persistent wheeze, and transient viral wheeze. So from the whole population, the algorithm managed to identify some clinically useful phenotypes. The next slide is a different approach, again, a data-driven approach. And I'm not sure what type of cluster analysis is this one, but again, they got into starting from lung function in this case, and then going into age of onset. They managed to define or divide asthma into 5 different clusters. If you start looking at the descriptions here on the right, you see that it becomes a bit complicated and not so easy to use in clinical practice. Early onset, atopic asthma, and preserved lung function, but increased medication requirements and healthcare use, for example, cluster 2. Even more, if we go to the next slide, when people have used different types of data-driven approaches, we don't end up with phenotypes that are the same. So basically, each type of approach and each population comes up with their role division, and this is probably because of the nature of the clustering approaches, and the fact that in most of these there was no kind of validation cohort, but people did. Here you can see the first one is K-means clustering, ended up in 5 clusters with based on airway inflammation and body mass index. Then you have a hierarchical clustering with 5 clusters, subgroups of asthma and COPD. Then you have another hierarchical clustering and latent class analysis with 4 clustering, but they're all more or less different. So we haven't managed to reach using these approaches, although they can be interesting and people are still looking at them, but we don't reach any specific conclusion on what we are going to do or what we can do with these clusters. One of the most promising approaches, and actually I've seen a paper also published yesterday in the latest issue of JACI, In the next slide, this is an older one, and it has come from a different type of analysis, which is called topographical modeling. And there again, you can use a lot of information in order to organize or to cluster patients depending on characteristics, and then you can see each of these groups, whether they have specific properties or not. And you can see here that there are interesting descriptions on one of these. For example, the healthy participants is this purple blue on the right side, which is apparently quite different from, on the upper left, you have severe asthma with frequent oral steroids, obese, non-atopic, predominantly female, high mast cell mediators. So there are some things. However, still, this type of approach, which seems to be quite interesting, it has not managed to get translated into something clinically useful. Now, I have just a couple more slides, and I will show you some thoughts that we have about a different type of clustering for asthma, which has to do with longitudinal activity. So these are charts of children. I think, yeah, they are children. They are people, anyway, who have asthma, and we're following them with diary cards every day. And you can see here, this is the total symptom score, I think, or it's probably the low respiratory symptom score, the asthma score. And you see that there are different patterns. You see that there are patients that have some symptoms and then they don't have for quite a bit of time. There are others that have most of the time, etc., etc. So we have tried in the next slide, and we have done that, in an arbitrary way, not in any kind of systematic way, but we have identified some different patterns, longitudinal patterns. For example, the first one on top, which is continuous. So within these 3 months of observation, 12 weeks of observation, you have patients that have symptoms all the time. Some which have symptoms and they become well when they come back again, called them relapsing. And some others that most of the time they're well, but then they have these exacerbations, and we call this episodic. So one suggestion that has not been used yet, and I think it can be used, and we'll need to look into that, is to look into longitudinal phenotyping. So this is something that has not yet been proposed, and I am sort of kind of proposing it, have been proposing it, and we need to look a little bit more on the dynamic in terms of time. Okay, so let's go to the conclusion. That's my 2 final slides. And the first thing is that physicians, everybody knows what asthma is. So every clinician will know what asthma is. But for the time being, nobody has managed to define it properly in a way that everybody else would agree, and in a way that we can refer to the definition for diagnosis, etc., etc. So it evades us. Clinical symptoms of asthma can be the result of several distinct but very overlapping pathophysiological pathways, what people have tried to describe as endotypes, but I think the truth is that we have a lot of overlap and a lot of redundancy in the pathways. Now, asthma can be classified according to different perspectives, and this is utilitarian, so it depends on what you want to achieve, and of course there's no right or wrong, but several of these proposals of these phenotypes can be helpful and meaningful in terms of management. But we have not managed to really separate asthma into separate boxes and agree that this is the more important one, or you have, let's say, 4 or 5 or 10 or 20 different specific phenotypes and endotypes. Let's go to the next slide. So very recently, I think it was last year, where there was a paper in Lancet, the Lancet Asthma Commission, where there was a lot. So some of the top people around asthma in the world have met and discussed about what are the unmet needs, and suggested that we should give up altogether using the word asthma with any kind of pathophysiology in mind, and just call asthma the symptoms, and then try to treat whatever you can identify that's treatable, and they call this treatable traits. And the eosinophils are very typical of this characteristic. So if you do find quite a lot of eosinophils, just give a medication that will lower the eosinophils, and this will most probably improve symptoms. So it's like, I mean, they suggest a kind of reboot. I'm not sure if we agree or not, but I suppose it's a matter of despair. You know, if the best people looking into asthma in the world cannot really find what it is, well, obviously we are not asking the right questions. So this is why I think that we do need disruptive innovation. We really need to look at it from very different perspectives. And in the last slide, I have a question to you, which is, will a cure can stand for the challenge? Okay, very happy to discuss.